Welcome to TMI, a podcast by Henry Ford Allegiance Health. We have a great topic today. It's going to be exciting. I'm getting pumped up.
Me too.
I get the blood flowing.
Yep.
Because we're talking about
the heart
stuff.
Yep.
It's going to be really fun. Jen is in the studio with me today.
Hi, Dave.
Again, welcome. You are the podcast queen.
Thank you.
And really fun to be on the show with you. Oh, and Jen, I wanted to make sure that people know that this podcast is informational. If you have any issues or questions, please consult your family physician or the doctor that you see.
Absolutely.
But like I said, we're going to be talking about heart-related topics today.
Mm-hmm. So
we brought in, just somebody who's an expert, somebody who's amazing. Matt Jonovich, welcome to the podcast.
Good morning. Thanks for hosting me.
And we wanted to bring you in because, we're just interested in these health topic things, and you know quite a bit about this kind of stuff. And I was doing one of your videos for the introduction when, like, kind of the welcome to the hospital kind of thing, or what people look up when they're looking for doctors. And I thought it was really interesting because you said one of the things that motivates you is like your family history and all that kind of stuff. That's how you connected with this originally. And I have the same kind of thing. My father had heart disease. He had stents and all that kind of stuff. And my grandfather, that's how he passed away when he was like 34. So
very early onset disease.
Exactly. Mm-hmm. So I've been kind of putting that in the back of my mind my whole life, and been like, wow, this is something that I should probably be kind of conscious of. So thanks for being on the show. And if you could talk to our audience a little bit and describe what you do in the health system here and what got you motivated to get into that.
Sure. Well, thanks again for having me. And I will say, unfortunately, your experience is not unique. It's quite common, in fact. Mm-hmm. And it's very similar and parallel to my own. Heart disease is so prevalent in the United States, and it touches many, many families, including mine. It's something that had affected my grandfather, who required stenting and bypass, and my father and my uncle, and certainly something, that resides in the back of my mind as far as those genetic risks we know that carry in families. Mm-hmm. So it was a big motivator for me to, study medicine first and cardiology thereafter. And, have a special passion about treating those patients and, helping them with this disease that is, so prevalent in our society and affects and touches so many families, unfortunately.
That's right. So what kind of things do you do in the health system here? What's your specialty, or what kind of things interest you?
Sure. So I am an interventional cardiologist. So I have training in cardiology and additional training in the subspecialty dealing with treatment of blockage in arteries. So I treat patients who present with heart attack or symptoms associated with heart artery disease. So things like chest pain or pressure or shortness of breath. And that's done through a minimally invasive technique where we're able to go into an artery, go up to the heart, and identify those blockages. And in many cases, treat them using balloons and stents, restoring blood flow and eliminating or diminishing those symptoms for patients. Mm-hmm. So that's a special passion of mine. I also treat peripheral vascular disease, meaning blockages affecting other territories of the body. So things like the legs or the kidney arteries or the abdominal arteries, which also yield patients a lot of symptoms and difficulties. Certainly I treat patients with other cardiac conditions as well, things like heart failure, for example, heart rhythm disturbances, high blood pressure, something else that's very, very common and we see in many patients.
Yeah.
Well, we know that February is Heart Month, and so there's a little bit extra focus on, just kind of paying attention to, what we can do to kind of make sure that we stay healthy, and all of that.
Yeah. And I know I have personally, gone into the emergency room a couple times just because I've been concerned. Mm-hmm. Like, I've had high blood pressure, I've had pain in the chest, like tightness, and like that feeling where you're just like dizzy or like not feel like you feel sick, like you're gonna
pass out,
feeling unwell.
Yeah. So I've done that. I've had that before, and my family or my physician's been great with helping me get my blood pressure down and that kind of stuff. But I wasn't quite sure what to what was going on, or like if this was like signs of early signs of heart disease or things like that. So what are some of those signs that we can look for so that we know, especially people like us that are a little more concerned? They're like, is this happening now? Should I get there immediately or call somebody? So,
well, I think there's a number of symptoms that patients might present with and should be aware of. Certainly, top of mind, patients are always watching out for a chest pain syndrome. And classically in men, that might be something like a heavy pressure sensation in the chest. We often hear it described as the elephant on the chest, or a heavy weight there.
Yeah, for me, it felt like I had to just stretch, and I couldn't stop stretching. I was like, oh, this can't be good.
Right, a tightness that's not relaxing or relieving.
Yeah.
That's particularly true if those are symptoms that might be triggered by or provoked in the context of either physical exertion, so maybe you're exercising or you're doing lawn work or you're moving things. Shoveling snow is a classic.
Oh, yeah.
Folks who might not be particularly active on a day-to-day suddenly exert themselves to a pretty high degree, moving heavy, wet snow in a cold environment, which we know in and of itself can be a risk for heart artery disease events.
Yeah, and for me, I think it was a time in life where I wasn't eating healthy, I wasn't being healthy, and I had an extreme amount of stress because I was running my own business and doing all sorts of stuff.
Well, you're absolutely right there. So, I mentioned first physical exertion, a very common provocation or trigger of symptoms, but so too is emotional stress. So often things, if you're having a high level of work stress, if you're having a high level of emotional or family stress, those acute stressors really can be a trigger as well. And we always talk about, the pain or pressure located in the central chest, triggered by exercise or emotional stress, relieved by quiet rest or medicines that can be helpful, things like nitroglycerin. Those are elements of what we call typical angina or cardiac chest pain and things that you should watch out for. But they're amongst many symptoms, chest pain, being chief that we think about, but often it's much more subtle. And I'd say that's especially true with women, for example.
Right.
They may present only with things like shortness of breath or fatigue, perhaps nausea, some unexplained sweating, even episodes of vomiting. Those types of things, too, can be a tell that something is up, and certainly they may be suffering an event or an escalation or unstable symptoms.
Wow.
So what should someone do if, you're noticing those symptoms? Is that something that we can just call and schedule a cardiology appointment, or is that something that's a little bit more serious that needs more immediate attention?
Well, I think it depends a lot on kind of the severity of the symptoms, their cadence, meaning are they, developing more quickly, more frequently, more severely in their presentation that would help to guide them. If you have a single episode of discomfort and it resolves relatively quickly, obviously not as high in acuity, certainly having a good relationship with a primary care physician is a great place to start. As far as, a thoughtful history and a thorough physical examination and some other basic instruments that can be used to evaluate your heart's health, like an EKG, for example, an electrical tracing of the heart. Certainly if you're having symptoms that are more persistent or more frequent, lasting chest pains, meaning lasting more than 5 or 10 minutes. Those are ones that you don't want to ignore. And I would say in that case, you should get in and get help. And whether that means having a family member bring you into the emergency department, or if you need to have an ambulance or a professional bring you in, but you don't want to be driving if you're having ongoing symptoms of that type, because you might put yourself or others at risk. And we certainly want you and them to be safe.
Yeah, if you feel like you need to go, you should probably go. Don't make
guess it.
Don't make a small inconvenience stop you.
Right. Yeah, absolutely.
Yeah. And when I went there, it was, I came in and I told them what was going on, and they're like, okay, go into this room right over here. It was like immediately they took me right in there, and I was there only for like 45 minutes. The whole
nice.
was out.
Not too bad.
Yeah, but I'm doing great now.
Well, good.
Glad to hear it. And certainly we have a great system developed of care where they can really identify a problem if one exists quickly, or, fortunately in your case, do the testing necessary to say there isn't something serious right this moment.
Right.
And so we can, provide you the reassurance and then a further investigation, at a more leisurely pace, which is a nice thing too.
Speaking of that further investigation, what kind of things could someone expect if they're like going into this more? Because I know sometimes people get freaked out. They're like, do I have to do a treadmill test? Do I have to do this stress test? I'm already stressed enough. Right. What are some of these things that people can expect? Or
Sure. So always, just like with us here today, we start with a conversation. And by that, I mean a history taking. So most often folks would see their primary care physician, kind of their initial touch point. Possibly they might see a specialist like myself, either initially or in referral. And so we're going to talk to you. We're going to ask a lot about what your symptoms are, their characteristic and location, their duration and severity, and what might trigger them to be worse or cause them to feel better. And those are helpful clues. So we're really kind of piecing together a puzzle, almost like detective work, to try to get us an idea of what not only what the condition is, but what might be triggering it. From there, we certainly are going to first start with just examining you thoughtfully and thoroughly. We're obviously going to listen very carefully to your cardiac sounds, examine your heart. But beyond that, we're going to do a vascular examination. We're going to check pulses throughout the body. We're going to check other related organ systems because there's often overlap with chest pain syndromes. They might be due to the heart, certainly, but they might also be due to a lung issue or a muscular issue, even an upper gastrointestinal problem, things like acid reflux. Many of those things feel very similar. And so it takes both some history and some examination to help tease out what we might be dealing with before we can move into a further investigation, using testing and other tools we have at our disposal.
Yeah.
Awesome.
Yeah, it's really pretty amazing the kind of stuff that they can do. And when you put the leads on your chest and do the EKG, and it's pretty cool. They can really see what's going on.
Yep. It
Absolutely.
gives you a little bit of peace of mind, I think, too.
As you mentioned, after we talk to you and examine you, an EKG is often our very first kind of diagnostic test. And it really has a wealth of information. It tells us very much about, obvious things like your heart rate, but more importantly, your heart rhythm. And is it a normal type of a rhythm? Does it represent some type of disturbance, which we call an arrhythmia, which can be associated with its own symptoms or complications, or maybe a marker of another problem? We get information about the absolute size of the heart, meaning the muscular thickness of the wall, which might speak to conditions like high blood pressure over many years, leading the muscle to thicken or hypertrophy. It also can show us if there's evidence of scar tissue, maybe from former or silent heart attack or other damage present there. So there's really a lot of information by that one single test, which we can do quickly at the bedside, that helps, again, to steer us to a further and more in-depth investigation and a diagnosis, really understanding what is your condition so that we can understand how best to treat it.
Very cool.
That's awesome. So what treatments are currently available? I know that, we're, as a health system, we're bringing in new procedures and all sorts of things. So, if you do find something, what are the options that a patient could have done?
Sure. So we have a lot of treatment options available, many more so now than even a few years ago, which is an exciting time for patients and doctors alike. And it really allows us to treat disease in a way that we couldn't a short time ago.
Yeah. Cool.
So it depends a lot on the diagnosis. We've talked a bit about a chest pain syndrome and an investigation of that. And in many folks, particularly in the United States and in Western countries, heart artery disease or coronary disease is very common. And if some of our investigation leads us to believe that might be the case, very often that would result in a definitive test to kind of evidence the presence or absence of that condition. And that's a test I do. It's called heart catheterization, done at the hospital. It's, in fact, a very routine test. We do thousands a year, and it helps us to get a very definitive answer. So patients' experience would be to have the test at the hospital where you come in and meet our nursing staff and are prepared. We give you a little IV, which is used to give you medication, and the test is done under sedation. So patients are completely pain-free and relaxed and have amnesia about the experience.
Sure.
We are now very often able to put a little catheter into a tiny artery in the wrist called the radial artery. Different than years ago where we had to use a bigger artery in the leg. And that's an important priority for patients. It allows us to complete a test to make a diagnosis and often provide therapy in the least invasive way possible, the least painful way possible, and with the least risk possible. A big risk anytime we embark on an invasive procedure might be bleeding, and we're able to reduce that risk to a third of what it once was by using these newer techniques in the arm.
Wow.
Yeah, I remember my father had the one in the leg, and he had to hang out and chill for a couple weeks after it happened. So the Transradial one, or the one in the arm, that's just incredible how less recovery time there is for that, and it's just pretty cool.
It's really kind of advanced at such a rapid pace. I remember years ago as a young child, my grandfather having a heart event and having a catheterization in the leg, and being in the hospital for days, and afterwards laying for hours and hours flat, and sandbags and pressure devices, and a lot involved there. And and a pretty protracted recovery from one of those procedures.
Yeah.
And seeing how it's done now in many, many of my patients who I've met in the office and have a suspicion of heart artery disease, we're actually able to do their procedure as what we call a same-day procedure.
Oh, wow.
Meaning they come in and have it done by that arm route or the radial artery, and within 30 minutes of the procedure, they are up and walking and going to the bathroom and eating and able to leave later that day.
Wow.
So really a same day kind of a surgery, which is very nice for patients, allowing them to recover where they're most comfortable in their own home, in their
Absolutely.
own bed, safely and without a need for a hospital stay.
Right.
That's awesome.
Yeah, and you can do so much with that. Open heart surgery is it's super important.
Sure.
But it's probably becoming less I don't know. What would you say
I think there's
about
been
that?
a change in kind of the frequency of heart surgery versus what it would have been years ago. Artery blockage obviously limits blood flow to the heart muscle and causes patient symptoms, chest pain or angina being one, potentially due to heart attack, weakening of the heart, or heart failure. And so when we identify this problem, we obviously want to treat it. And that used to mean bypassing around the arteries with relative frequency. Using things like other arteries on the inside of the chest wall, or redirecting and taking out veins from the leg to use as a conduit, a passageway for blood, and sewing them onto the heart. But what we find now is we're able to do treat many, many patients using catheters, using balloons to kind of displace or stretch that cholesterol plaque out of the way, and a metal coil called a stent, which is essentially like a circular scaffold. And we place it into the artery. It's inflated with a balloon so that it grows in size, and it essentially props up or holds open that artery, pushing the cholesterol plaque out of the way, allowing the blood flow to be restored. All that's done through a small tube in the wrist most often, sometimes the leg. And so the recovery time obviously is much quicker than a big open operation, a bypass surgery. Whenever it's appropriate to do so for patients, we want to offer that as a treatment option because it's less invasive. It's a lesser recovery time. It's a more cost-effective treatment. But there are still patients clearly that warrant and benefit most from a bypass. If they have very advanced heart artery disease or multiple blockages, those are patients where still bypass surgery is the gold standard, and it's the one that benefits them the most.
Yeah.
And so we work very effectively at our institution in a collaborative team. We have what we call a heart team. And that involves members of our cardiac surgery department, members of our interventional cardiology core, general cardiologists, so that we can assess each patient and think about what's the best way to treat them in a comprehensive fashion, to restore their blood flow most completely, to do so, in the best available way for the patient.
Yeah, and that's one of the things I think is so cool about our heart team here is they are always looking at these new techniques and new things, but they're only using them if they're more effective or they're more appropriate. They're not pushing the envelope just to try and do something new. It's
Sure,
whatever
absolutely.
is best for the patient and whatever fits their need.
Absolutely. One of the most exciting things about kind of that space of interventional cardiology and cardiac surgery is we're always innovating, and we're always doing so with an eye on outcomes and results for patients. And so we have really a wealth of clinical data and thoughtfully and well-designed randomized clinical trials that help us to know what's the best treatment. There's many, many developments there, and quite often they offer a better and faster and easier recovery treatment for patients. Sometimes they don't have the results we might expect, and that's why we do those trials so that we know we are only offering to patients ones that will benefit them most. And certainly it's an exciting time to work in the field and to treat and help patients there.
Yeah, I know we have a bunch of new things that we're working on right now, but we don't have time to get into all of them during the podcast, but it's cool to see you guys just looking into these new areas.
Yeah.
So is there anything else you would say to somebody who's listening to this podcast and I don't know, what kind of encouragement would you give to them about the prospect of having to have something done?
Well, I would say certainly don't be afraid of and don't ignore symptoms. There's so much that we can offer you to, alleviate or eliminate symptoms to prevent complications of illness in the cardiac realm. And so I'd say, have those conversations with the folks you trust most, your primary care physician, your nurse practitioner, your PA, get evaluated and get treated. And so many patients, you and I being some that have it in the family and have it in the back of their mind, it's even reasonable to have, make sure you're having those well visits and to have an evaluation done. In fact, one of the newer techniques that we have available now is kind of an in-depth assessment by way of a CAT scan or a CT scan that can help us to know about the presence and burden of heart artery disease, even in patients who may not be symptomatic. Wow. So something called a coronary calcium score, which can be very insightful to patients and very helpful to doctors in knowing how to augment treatments of patients who maybe haven't yet presented with chest pain, but have risk factors like family history of early onset disease, high blood pressure, high cholesterol, diabetes, a history of or present smoking. All of these things we know contribute to risk, and maybe put in someone's mind a concern about that. And so we're able to actually help them to know whether or not there's artery disease present and how better to treat it, to prevent it from presenting with chest pain or presenting with heart attack, which is what we really want to prevent.
Right.
Yeah.
And unfortunately, even today, up to a third of patients, present with heart attack. And in fact, with a complication of heart attack, heart rhythm disturbance called sudden cardiac death. So we don't want you presenting in that fashion. We want you presenting, with symptoms and allowing us to make an early diagnosis and execute a more complete treatment.
Right. For me, the idea, thinking of all the possible things that could happen, procedures I'd have to have done was what made me not want to go in. But then I thought about it, and it's really, you just start with a conversation and just talking. And the earlier you do that, the better off you'll be.
Absolutely. We always start building a relationship, and that's something I always strive to do and place a lot of value on my patients. And I think that helps. It's a relationship where we want to, listen to the patient, their preferences, their needs, their concerns or fears, and also share with them, what we know about the disease and how can we educate them. Because when we share that knowledge, that really helps to abate those fears and to, help them to realize and normalize this is a common thing. It's a treatable thing, and it's something that we can really take care of well.
That's great.
That's awesome.
Well, Matt, thanks for coming into the studio today and talking with us about all this. And it's been great, and I think it's been informative.
It definitely has. And we're really looking forward to continuing our journey. I think this kind of gives us a lot of information and just kind of help us make a little bit healthier and smarter choices in our daily lives. And yeah.
Yeah. And speaking of smart choices, if you'd like to subscribe to this podcast, you can go to henryford.com/podcast, and we're on there. And we're also in iTunes and a bunch of other places. So we've got a lot more topics to talk about, and we hope you listen.
Yeah, sounds good.
Thank you so much for having me. It was really a pleasure.
Thank you.
Thank you.